respected Dr. Sujata Chaudhary ji, Dr. Shanta Singh ji, Ram Mohan ji, Avinash ji, Nataraj ji, Vamsi Krishna ji, and all the executive directors, superintendents, vice superintendents, and all the stakeholders that are involved in this patient safety who have come across the country, as Vamsi ji said earlier, Kashmir to Kanyakumari, which is true. Thank you for taking the time and pain to reach here. But I hope you all must have appreciated the beautiful campus of AIIMS here. I mean, these are the times of reflection as well. These campuses are not born just like that. There is a tremendous amount of hard work involved in building these campuses, whether it is the vision of Sri Narendra Modi ji or Sri Nadda ji, or identifying the site between three hills with huge forest between, our visionary leader Sri Nara Chandrababu Naidu Garu, and all the government officials involved in this process. I also wanted to thank for completely utilizing the existing campus by sanctioning additional posts, Sri Nirmala Sitharaman ji and Nitin Gadkari ji for giving access roads, and also Nadda ji for facilitating all of these things for the people of Guntur and Mangalagiri area. So I wanted to thank you for that. And second, I am not supposed to be here, but some reason yesterday they told me Nadda ji was not able to come. Can you come and talk about this patient safety? I said, usually I am quite organized and I plan my events 1 week before, but patient safety is something that I have deep experience in the United States for the last 25 years. I thought I could add some value. That's why I decided to come here. So thank you for inviting me. This is a passionate subject for me, and I hope my talk would be somewhat useful to you. And second, this patient safety is an important topic. Why? Why it is such an important topic? Can any of you guess how many deaths are happening because of the medical errors within the hospital systems in India? Can anybody guess what would be the total number annually? So it's 5 million. So 50 lakh people are dying annually in India because of the healthcare related errors. I mean, it's a staggering number. If you take the same numbers in United States, annually it is around 250,000 deaths. Of course, we have 4 to 5 times population, but even if you multiply that, their death rate is 1 million, population adjusted metric, and we are 5 million. So we are 5 times more. And the average adverse event rate in US, if you take it, around 3 to 10%, depending on the studies across, but where we are 16 to 18% across all our admissions in India. I mean, these statistics are not to give you in a comparative downgrade, but it is actually to empower you and educate you why this is important. Second, medical safety is something that distills during the time of education. It's in the medical colleges. You look at it, even United States being such an advanced country, spending billions of dollars for building the safety net, was not included in the educational system until 3 years ago. 3 years ago, they have instilled the entire patient safety into the medical educational curriculum. Now it's being routinely tested. I see a lot of medical students here. If any of you are planning to write USMLE, this topic is extremely important for you. So you pay attention to some of the things that I'm going to tell you. But even here, I suggest, since the Department of Health Sciences is here, until you put these things into the curriculum and you test some way, sometimes people may not take it seriously, and I request to consider that. That's one suggestion I have. So, and the medical colleges are such an important, and teaching hospitals, these are promoters of excellence. And I'm glad the government of India is actually recognizing some of these things so that we can truly become a developed nation by 2047. Without really understanding these and fixing these, we cannot become a developed nation by 2047. So I wanted to thank you for the health ministry for recognizing this. And number three, the reason is, if you look at it, in the medical, anybody, a physician or healthcare professional who takes an oath, start with first to do no harm. So what does that mean? In a complex, high pressure and limited resource environment, this ancient principle is our most vital anchor. If we remember that first to do no harm. Therefore, that is the third thing why this is morally, ethically, it is the highest calling point, because when you have limited resources and when you cannot fix the system, whether it is reporting or actually finding an appropriate solution, may be beyond many people control, given the current healthcare system. However, having that moral principle and doing the things that are within your control can make a huge difference, and I'll give you some examples on why. And fourth, building a true culture of safety. This is a commitment by the leadership. Therefore, all the superintendents or executive directors, principals, deans, whoever have been, who are all here, your processes, checklist, everything that you do is what makes the system really work. Therefore, the leadership commitment and believing this is extremely important. And the fifth reason is for our own health. I mean, you look at it, some of the richest people, even today, if they have a serious illness, they try to travel abroad. Why? Fundamentally, there is a trust issue. Why is the trust issue happening? I mean, these are the reasons. Safety is one of the foundation of the trust, as everyone have said. And you look at one of the reasons in patient safety, one of the problems of the not implementing patient safety is, for just to give you an example, antimicrobial resistance. Today, 1 in 10 patients, that is 10% of the patients, acquire infection in the hospital across the world. However, by 2050, antimicrobial resistance will lead to 10 million annual deaths. That means 1 crore people will die if we run out of antibiotics. Therefore, if we lose antibiotics, we are essentially losing modern medicine. So we have to remember that. And how do we do that? And obviously there are structured, blood transfusion errors, infection error prevention. These are all good when you take it individually. But you need to have a structural framework how you look at the patient safety. It starts with whether it is education or anywhere, you really need to understand the definition. Definitions of the patient safety. What are the preventable medical errors? Non-preventable medical errors. Because it makes a huge difference. Non-preventable error, for example, if somebody takes an antibiotic and you get anaphylaxis and people might die. But there is not a whole lot we can do. Obviously, you can do certain extent if the patient already has a known allergy and other stuff. But largely, you may not be able to do something. However, but if you are administering a medication to a person that you already know that there is an allergy, it's obviously a preventable medical error. All it needs is a proper tag to identify the patient allergy, document it, and a nurse can simply ask, or a pharmacist or a physician can ask. That much important to understand the definition, whether it is a sentinel event or near miss event. These need to be known. And the definition between an active error, a latent error, what is the difference between active errors or the frontline errors? Whereas the latent errors, these are the things that go under the rug, that it would take a lot of time and multiple errors before you can actually identify an error. So understanding these definitions are important. Second, and understanding the causes of error is also important. Again, if you lump broadly like infection and all that stuff, you may not get the complete picture because it has a patient-related errors, provider-based errors, and a system-based errors. Patient-based errors, for example, you could provide the best medicine, for example, insulin for a type 1 diabetic. I was in in Guntur General Hospital looking at a child, an 8-year-old, came in with diabetic ketoacidosis. I asked what happened. Obviously the patient was not taking insulin. Why they are not taking insulin? Because they cannot afford, so they are mixing or they are missing the doses. I mean, these are the patient literacy, understanding that they really, what will happen to them if they don't take. So somebody, whether the nurse or a physician, taking the time to explain these things, the literacy issues, it is a simple fixing. That doesn't require a lot of money. It requires a human motivation and interaction. Cultural factors, language barriers, obviously, you have a lot of taboos. People may not come to the hospital. Again, exploring with the open-ended communication and understanding the patient deeply will help you. And then the provider basis, right? A lot of providers, we think here, especially in a lot of places, once we are done with the medical college or residency, we think we have mastered everything. But unfortunately, medicine is changing so much. Every doctor must be a lifelong student. A best doctor is a lifelong student. But people are so busy in seeing patients, they don't pay attention. And even in these medical knowledge, where can we do mistakes? That's when common things every doctor knows. But where, like for example, we have in Guntur recently a melidiosis patient. It's an uncommon disease. But what uncommon diseases can actually kill you? In mental prioritization of the physicians when they are learning on these not every rare disease need to be mastered, but if it is going to cause a lot of death, obviously this needs to be mastered, and this needs to be instilled into the medical education, whether it is a knowledge deficiency prioritization. And then cognitive bias. As we see more and more patients, we develop mental shortcuts, heuristics. These things will automatically make you think one diagnosis when in fact it is not. Therefore, while heuristics are important, constantly having in the background, what if my diagnosis is wrong? Again, this is a mindset of a physician to think, at least taking a minute, I diagnose, but am I accurate? Am I missing something? If you take that 1 minute, you will likely to explore a lot more. So bringing these stuff into the medical college and education, again, saves a lot of time and problems for us. And then environmental and systemic factors. I mean, there are a lot of things, right? Physician and broken infusion pumps, they're all talking about cluttered medication rooms, similar looking medication packaging, and excessive noise. All this stuff are there. But organizationally, if you build a hospital with a culture where productivity is rewarded over safety, then you lose the picture. You cannot make productivity alone as your primary goal. Obviously you have to balance it, and you can improve the productivity. And then the most important aspect is leadership, suboptimal teamwork. What does that mean? Ill-defined roles. People exactly don't know what to do. Low trust between the people. And steep hierarchical gradients. I'll tell you what it is. When I went to US, after my medical school, I went to residency. First few weeks, I used to call my attending physician, sir. They used to look at me in a different way, embarrassing way. Why are you calling us sir? But that is what we used to call in my medical school, sir, 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 sir. In US, nobody calls one person a sir. Everybody is equal. Everybody is contributing to the patient care equally. So, removing some of these hierarchical barriers is extremely important, so that they will have a psychological safety to explain and to complain if something happens. So this is extremely important to build this kind of model. And in the, obviously there are models that you can fix in the environment, Swiss cheese model, where, things happen because multiple mistakes happen repeatedly. But if you put multiple barriers at each level, hopefully some of these problems can be resolved. You look at high reliability organizations, right? Whether it is aviation industry or nuclear power, these things, they're a lot more dangerous. But you rarely see accidents there. Why? Again, because they take these things very seriously. They apply the brain. They go problem by problem, each area where you can fix this. So, understanding how high reliability organizations work is important. And then human factor engineering. I have seen it, I listen to the equipment manufacturers, but this is an area where a lot of the manufacturers can come up with creative solutions, innovation, smart solutions, because a good design saves a patient even a doctor enters into the room, before a doctor enters into the room. So forcing functions, automation, standardization, visual cues. So these are the things I am sure equipment people will understand. They read the best practices around the world and build those. And the medication errors is probably the easiest one to prevent, right? These are the, how many times physicians means ineligible handwriting is the way that most people identify as this is a doctor written prescription, right? Obviously having electronic medical records would help, but at least meanwhile, doctors can consciously write it. If a patient or somebody cannot understand your prescription, your medicine is powerless. Why do you want to do that, right? These are the basic things. And then focusing on when you are writing these, putting the decimals instead of 5.0, 50. These are the things can create a lot of errors. And again, prioritizing which medications can cause death. Okay, if you cannot do every medicine, at least focus on anticoagulants, insulin. These are high priority medications. You have to be really, really careful whether they are administering IV versus IM, those kind of stuff. And then the procedural and surgical errors. It's interesting. Wrong patient and wrong site, even today, even in the most developed nations, is a huge problem. Despite having a preoperative verification, timeout, all of this, still these things are happening. Retained foreign objects, again these things are happening. But again, the equipment manufacturers, if you can build radio opaque materials, at least that can be recognized off with the X-ray. And then injury to the structures like pneumothorax and all that stuff. You have these days, even when I was in residency, we used to do central line placement. You get a lot of pneumothorax. Now you have whether IV puncture and everything, there are infrared based visualizations. That needs to be at least in the premier institutions. If you can train them how to use that, you can prevent a lot of errors. And transfusion errors, easiest to prevent. All you need to do is maintain a 2 patient identifiers, double checks, like this. And healthcare infections. The infections, simple ones, even in US, I used to have Foley catheters in every patient. Within 24 hours, no catheter should be there, right? Foley catheter, this should be like physician or nurse every morning should think, does the patient need a Foley catheter? They put it in the operating room, they leave it, they will never take it out. You get UTIs. Like these, simple mechanisms can solve a lot of these problems. It requires systematic explanation of the basic stuff. And obviously, there are transition of care errors. When you are going from ICU to, step down unit, or when you are discharging a patient, it is important to write a very good discharge summary. Because a lot of people, once you are done, you are not, patient is here 10 days, 20 days, 30 days, nobody gives a good discharge summary. So one day I remember, especially, if you cannot provide for everybody, at least the most critical patients, transplant patients do. I remember in one hospital, there was a renal transplant patient came to me. and we took care of that patient, highly complicated, 2 days, 2 weeks or something. Then I sent a discharge summary. The patient came from a different city. And the renal transplant surgeon, he actually called me later on saying that your discharge summary was so helpful. Thank you for doing this. Because we lost so much data. We don't understand what they have given, and it helps so much. Because that is the value. You just have to take time and do those, because these patients are highly complex on multiple medications, a lot of drug-drug interactions, and everybody has to take. And then communication techniques, right? This is another area where I don't know whether you apply S-bar technique or IPAS. Do you do that in the AIIMS? No. See, communication is simple, right? Handover, doctors change, morning, evening, nurses shift changes. But you have to communicate. What is the mechanism to communicate? Everything has been invented somewhere in the world. You don't have to invent. All you have to do is copy and put it in your systems. Like S-bar, situation, background, assessment, and recommendation. Any patient, what is the situation? Does the patient has pulmonary embolism? Right? What is your assessment? What are their vitals? Right? And and then what are your recommendations? At least they should be getting like IV heparin. If you give that prioritized communication, instead of overloading the oncoming person, these things would help. And device-related errors are basic, malfunction, programming errors that you can do. And the most important thing, ultimately, for this program to be successful, how you report the errors. So we don't have a centralized mechanism at this time, but at least you can create a team, a patient safety team within the hospital, and everybody should be able to come and report that, and you have to advertise that. But when you report, it has to be non-punitive. It must be a simplified reporting mechanism. It cannot be a burden so that other people have to fill like long 2-3 page forms, then they will never report. It has to be within 1 to 2 minutes. Somebody should be able to, you put a small number or something nice, simple number within the hospital. They should be able to call and report, and somebody writes it, right? But if you have like large incident report, nobody will do it. And it should be role independent. Role independent means anybody should be able to report it. It could be a person who is moving the stretcher. It should not only be a doctor. Every person should be encouraged to do that. And it must be actionable. You have to provide some kind of outcomes from what you have done. And the other thing that we do often is that loses the trust. In the long run, these things are important. All these medical errors, it's good, we're building the safety, but patient disclosure is something that we often forget. Because when we tell the patient that we made an error, everybody fears there will be lawsuits, there will be unhappiness. But it's not true. Even in the United States, people who report error have less chances of lawsuit than the people who actually hide the truth. Because at some point, right now people may be somewhat, not educational, but eventually at some point people will be smart enough to know what happened. When they figure out that you hid the truth, then they will be a lot more angry. Instead, if you tell them what happened and what you are doing to prevent this in the future, and you are empathetically apologize, people will accept it. And that creates, then what happens is a trust builds. That is how you build the trust in the hospital system. Yes, that person will go and tell, yes, they made a mistake, but they have told me. And this is how the name of the institution improves in the long run. And ultimately, once you get these errors, you have to have error analysis. Regular residents or nurses, everybody at the chief nursing officer, whoever the title name is, you must do regular morbidity and mortality conferences. Because when I was in residency, every week we have M&M, morbidity and mortality. In the morning, whichever patient went wrong because of the systemic issues, they discuss openly. It's not about criticizing, but it is understanding why the systems fail. So doing that regular morbidity, mortality conferences, root cause analysis, all these things And the infection control, basic creating wash basin next to each patient room, regular, gown, these kind of stuff again, alone will prevent a lot of infections. But my point here is not everything is related to the money, not everything related to the high tech. It is mostly related to our intention, our mindset that we really want to take care of our people and do as much good as possible. So my suggestion, and then some of these, as a hospital administrators, you should put like real checklist and pathways for all the important things, whether it is a sliding scale insulin or monitoring INR. You should have a protocols in your own hospital. If you do, again, these are the things that if one hospital, they're all available online, but anybody with it, fortunately, all the people here are doctors. It's rare in the entire dais being occupied by doctors here, and you have a good doctor team. But as a system-wide, if we can generate these standardized protocol, national protocols, and distribute, everybody should follow that. It's easy. Again, you don't have to create. Everything is available on the internet. You just have to assemble them, create a policy, and drive it. So these are the things I wanted to tell you, but I just hope these kind of conferences are needed. Not everything will be absorbed at one time, but eventually with multiple times, everybody will improve. I hope when our children look back, let them say, this was the generation that transformed Indian healthcare, and I wish and I want to be part of that generation, and I hope all of you also want to be part of this generation. And I wholeheartedly thank you for all of you for inviting me and listening me patiently. Once again, thank you, and I hope you will have a splendid time here. Hopefully, in the next 2 to 3 years, we're building our Chief Minister, Honorable Visionary Chief Minister is building a beautiful Amaravati capital, which will be unlike anything else in India. So at that time, maybe we will have even a better convention hall, and we can have even a bigger conferences like these. So once again, thank you. Thank you once again.